as you mentioned, in clinical practice, stroke patients can be quite diverse. It's not the patients we always see in clinical trials. So Jesse, I would like to ask you how you deal with competing risks, frailty, or complex comorbidities in your patients. Would it be all possible that you provide, a few clinical scenarios and how you deal with, with the targets, the agents, and how you approach those individuals?
Yeah, absolutely. So it obviously is a huge area, and I think we have a number of different things when we think about personalized secondary stroke prevention to consider. One is that stroke is very heterogeneous, and even within the subtypes of stroke, we then have very heterogeneous patients, as you say, and the very elderly and frail are really, really, really important examples. And I think at the heart of this debate, really, or this question, is the risk of harm, isn't it? We know that an antithrombotic will have a similar effect in terms of thinning somebody's blood and reducing the risk of a thrombus, but it may come with greater risk if somebody is very elderly and frail, for example, and have increased bleeding risk. And it's the same with blood pressure reduction, as I mentioned before. And one of the key areas to consider is the efficacy of some of these drugs. When we talk about a 30% relative risk reduction, that might mean something very different in a patient who has a limited life expectancy because they're old and frail and are likely to sadly die or succumb to other conditions such as dementia and neurodegenerative disorders that might not be receptive to the effects of blood pressure lowering, for example. And the same with lipid lowering. So I think we definitely need to take these things into account and consider the risks of the approaches that we're considering for patients. So while we have the narrative that we want to be more aggressive and do more, and we've heard lots of good examples of why we might want to do that, be sure that we're not putting specific groups of people at unnecessary risk, and making sure that we treat them well. So I think with the elderly and frail, it's relatively straightforward. We need to be sensible. We need to think of the benefits for that individual person and interpret the clinical evidence in that light. And I think the other really important clinical scenario that I think we're getting much better at in stroke is remember that people with stroke have other conditions too. These are people with a high risk of recurrent vascular disease, often because they have comorbidities such as diabetes, comorbidities such as heart failure, atrial fibrillation, and ischemic heart disease. And sometimes those conditions might lead us to do slightly different things within the core pillars of secondary prevention that we routinely do. So, for example, if you have a patient who's already on an antiplatelet who comes in with a recurrent stroke and who also has ischemic heart disease, we could begin to ask ourselves questions like, well, does the fact they have ischemic heart disease empower me to do more for this person in terms of prevention? So as Joe's very elegantly outlined, is there a case now, can I access more aggressive lipid lowering treatment? Should I be going for an LDL of less than 1.4 as opposed to 1.8 and thinking about add-on therapy? Or could I use the COMPASS regimen? Could I use an antiplatelet plus a low dose of an anticoagulant, for example, in a person who has ischemic heart disease and cerebrovascular disease as well? And I think a really hot topic with regard to the other patient groups are now people with diabetes and people with excess weight. These are really high risk individuals, and why should we leave a risk factor like poor metabolic health or excess weight on the table these days when we can perhaps access GLP-1 agonists or other approved therapies to improve that person's or reduce that person's risk of having further events. And I think just to highlight one final area, which I think is really, really interesting, and I think we don't have the evidence base that we need, and that is, what do we do when somebody comes in with a vascular event whilst taking what we think is good preventative therapy on the surface? So they're on an antiplatelet, for example, they're on clopidogrel, and they come in and have another event. What should we do in that setting? And I'm not advocating there's a particular answer with regard to switch or continue, those sorts of things, but we should always use that as an opportunity to think about why might that treatment not be working for an individual person. You know, are they forgetting because of the drug regimen, or is there a drug interaction that's minimizing efficacy of one drug, or do they have some other untapped, unidentified risk factors such as paroxysmal atrial fibrillation that we could look for, screen for, and thereby treat them differently. So again, to surmise that, I think that the key patient groups to think about where things can be difficult and where we might need to personalize are the very elderly and frail, as you said. Remember the comorbidities and use them as a means to empower you to access better preventative treatments for your patients. And also just think about patients who come in with recurrent events despite being on what we think is good treatment, and think really hard about whether there's a reason why that regimen hasn't had the effect that you would like it to have had.
Thank you so much, Jesse. All points are excellent, and thank you for sharing, how you approach those very high-risk patient populations.